What is the clinical grade of the goiter? This is easy, man.
Grade 3, sir.
Okay, grade 3 of whom? Or if I ask you the clinical grading of a goiter, what is the clinical grading that you know of?
So now I have forgotten. In grade 2 is a palpable but not visible, and grade 3 is a visible.
WHO grading, sir.
Right. So I think the simple one that we use is a WHO grading. What is the WHO grading or WHO classification of goiter? Grade 0 is when no goiter is seen or felt. Grade 1 is what? Grade 1 is a palpable goiter. That means it is felt, not seen. Okay. And this kind of goiter is not seen in a normal condition of the neck. That means it may be seen when there is an extension of the neck. Mind you, this one. This is the trick in the question. Grade 1 goiter may be seen in an extension of the neck. Grade 2 goiter is when it is seen in a neutral state of the neck. Okay. So this is what I know about the grading. Some people have added a grade 3, which means a monstrous goiter. That means the goiter is beyond the level of the clavicles visibly. It's technically called as a monstrous goiter. Okay. So this is all about important things. So people have used about these goiters. If you have said this, I am happy. What is the complication that has been shown in such a goiter? I think this is an easy one.
SVC syndrome.
What is the okay, SVC syndrome is a good one, but I need a more specific answer, sir.
Tracheomalacia.
Tracheomalacia.
Come on, guys, this was an easy one. Have you heard about this complication?
The Pimberton sign is positive.
Have you heard about this name? The examiner wanted to ask you this one. If you have mentioned an SVC compress, if you have mentioned a thoracic outlet syndrome, all are good. But the better word I feel will be, if you see our books of surgery, starting from Bailey Love to S-Das to everything, I think the better word will always be retrosternal prolongation. And one of you have said that, and I really liked it. The test that has been shown is this lady has lifted her hands above, and you can see the positive Pimberton test. Okay, that's it. Now, a good question for your Viva. What is the reason about the Pimberton test being positive? Or in a retrosternal goiter, why does the Pimberton sign or the Pimberton test, whatever you call this to be, becomes positive?
Sir, in the hyperabduction of the both arm causing the narrowing of the inlet.
Very good.
Cephalic vein is compressing and causing the congestion of the face.
Okay. Perfectly said. I just needed one word for an examination. This is called as, Swartz mentions it very beautifully, cork in a bottle phenomenon. Cork in a bottle phenomenon. What is this cork in a bottle phenomenon? It means that if you take a bottle and this is the cork. So the cork in this case is the thyroid. The bottle is the thorax, and the neck of the bottle is the thoracic inlet. So whenever the patient is raising the hands above, what happens is that the two ends of the clavicle are moving close together, and it is said that rather than the thyroid coming as a cork, which is a more common belief, it is more problematic that these veins, that means the internal jugular veins, they become very narrowly compressed by the thyroid, which is trying to descend in this space. So this is the reason about a Pimberton test happening. And believe me, something in the anterior mediastinum, like a large thymomas or a growth, can also sometimes present with a Pemberton sign if it is compressing upon the trachea. Okay, so this completes the story. Now this patient underwent a surgery. What is the investigation of choice to plan the route of surgery? Understand the question very nicely.
Sir, triple assessment, USG and FNSC to rule out the
No, sir. Question is very
CT neck and thorax. Sir, CT
PCT
thorax.
thorax.
Neck and
very
thorax.
good.
Endometrial laryngoscopy.
If you have read Bailey Love, this is an MCQ, sir. We are not interested in the triple assessment of thyroid. This question is not about this. You are being shown a picture, and I hope all of you have understood what is the what is this part? What is this thing?
Retrosternal
extension.
Component. Exactly. So guys, how do you see the retrosternal component? What is the investigation of choice to plan your operation? Is always a
We have
CT,
to do CT thorax.
CT neck or CT chest?
CT neck with upper chest.
That's a diplomatic answer, sir. You are given two choices.
from root of neck up to the thorax.
Yeah, that is something that I know that. You are given two choices. I have not given you that one. So which one will you do?
CT
Sir,
chest. CT chest.
Yes, sir. My main concern is nothing in the neck. My main approach that I am going to take is, by the way, how do you define a retrosternal goiter? This is the goiter.
Won't we say CCT chest? I have with neck.
Okay, sir, I'm not the HRCT, CCT chest. I'm not that interested. I'm interested in you taking a decision. To begin with, what is a retrosternal goiter according to your definition? How do you define it?
When the
Goiter
lower border of
extended to
the
the
goiter cannot be palpable, sir.
Beyond
That's
the
it.
level of clavicle.
So that is as in this patient, the lower level of goiter is not palpable clinically. So
Clinically.
that is the definition of a retrosternal goiter. But under a CT scan, what is important is people consider that if there is more than 50%, if there is more than 50% of the goiter, definitely it has to be a primary goiter. That means this has to be the same one. It cannot be a different one. So it is considered that everything is the same mass, in which 50% is below the level of the clavicle. That is considered by many people to be a retrosternal goiter. But they differ. But on a clinical note, as you have very rightly said, if I cannot feel the lower border, Pemberton positive, I will consider this to be retrosternal. But many people consider that no, if it is more than 50% in the thorax, it is considered to be retrosternal. Now, what is so special about it? Why are people classifying them? There are various ways of classification. Please use whatever is convenient. For me, if I am asked what is the classification, what I do is that 1 or grade 1 is the one that reaches up till the arch of the aorta. So if the arch of the aorta is this and it is coming from the heart, so grade 1 is reaching up till the arch of the aorta. Why am I so worried with this? Because in grade 1, what is the access route that I will follow? I can go with a cervical incision. I can take out this one. What is a grade 2 goiter? A grade 2 goiter is one where the same thing is now.
Sir, this grade is based on CT.
Yeah, absolutely, sir.
Okay.
The grade is
It's
based on CT. This is the reason I did a CT chest.
okay.
You see, a grade 2 is something in which this goiter is reaching up till the convex part of the arch of aorta, whereas a grade 3 will be something that is below this arch of aorta. So it's a not a difficult one to appreciate. And as a surgeon like you and me, this is important because these ones, this is something that I cannot do. I need to call in my thoracic colleague, and they are to do a sternotomy to take out this one. Okay, but grace be the God, This is in 95% of the cases, this is the story. Okay, so majority of the cases of a retrosternal goiter are easily accessed through a neck. And can you tell me what is the blood supply of this neck component? Oh, sorry, the component inside the
Inferior
chest.
thyroid artery.
Very good. So the main blood supply of the component inside the chest is inferior thyroid. Very good. And while doing this or while coaxing this material out, what is the nerve that may be injured?
Recurrent
The
laryngeal.
recurrent laryngeal nerve, particularly on which
laryngeal nerve.
side do you think is more at a danger of being
Right,
involved?
right side.
No, not
Left side.
the left recurrent laryngeal nerve, because the left recurrent laryngeal nerve, remember what is the route that the left recurrent laryngeal nerve took? It
Uh,
hooked
Sir, is
crossing
wind
the
around the arch of
crossing
momentum,
crossing the arch of aorta.
crossing the arch of aorta. So it becomes a tough one. And definitely, if you are doing a sternotomy, I do not, my experience is zero on this one. I have done retrosternal goiters, but with a cervical approach. Believe me, and at that time, when you take out that thoracic component, it does become a bit scary because you have the brachiocephalic vein in view, and that does become a bit scary. But this is all about things that you should know about this one. What is the specimen doing? Specimen is doing a retrosternal goiter. Okay. So we complete
Sir,
this
one
one.
question.
Yeah,
One
please.
question. If it is a sir, secondary retrosternal goiter and it is a grade 1 goiter, then what is the route of approach to the surgery?
So secondary retrosternal goiters means that you are talking about something which is separate from the neck and there is no connection between the two.
Yes.
So if there is no connection between the two, this is what I understand by the term secondary, because see,
Right to blood supply from the thorax.
the blood supply is not coming from the inferior thyroid, and I presume that the picture is will not like be then. So that means I presume that there is a gap between the neck and the chest component. So that is something that will always require to do a sternotomy. You cannot, because the blood supply will be coming from the bronchial arteries, the veins will be from the brachiocephalic, or it will be something to do with the local vascularity. So I think I will be taking a I will be taking a sternotomy in that case.
Okay.
Okay, right. What is this device that is used in thyroid?
Sir, sorry, sir. I have another question regarding the previous.
Yeah. Yes, madam.
Sir, in this grading system, in grade 1, you said that it reaches up to arch of aorta, and in grade 2, reaching up to convexity of arch of aorta. So, what's the difference? I could not get
Madam,
that.
it reaches up to, that means it is not touching the arch of aorta. On a CT image, you can clearly distinguish between the arch of aorta, which is away from this one. Okay. So
Okay,
on a
sir.
technical note, if it is touching on a CT scan, you can see the border of the thyroid touching the convexity of the aorta. That will be a grade 2. If it is away from the arch of aorta, that means there is a fat plane. That means there is a blackness around that thing, and you can see very clearly the arch of aorta. That will be a grade 1.
Okay, thank you, sir.
Okay. Right. Now, what is this device that is used in thyroid surgery?
Armored endotracheal tube.
Very good. Perfectly said. If you have used the word armored, if you use the word metallic, if you have used the word non-compressible, all of them are the that are used for this one. Now, what is the
Wire
specific?
reinforced.
Nerve monitoring, sir.
Wait, sir. Wait. This is the reason I gave this question, and this is the reason I gave this question.
Oh, okay, sir.
What is this device?
This
Sir, first time I have one.
Nerve monitoring device.
Very good. This
nerve monitoring.
a intraoperative nerve monitoring device that is used for thyroid surgery. Okay, what is the particular nerve that I want to save? You all know about this one. My logic is to save the recurrent laryngeal and the external laryngeal nerve. Okay, so this is the usual commoner route for these ones. It is usually done by our anesthesia guys. My anesthesia guys do not use this, but if you have read Bailey Love again, Bailey Love says that intraoperative nerve monitoring is becoming a popular one. But how is it done? Definitely, these are called as the electrodes, and these electrodes are on the surface of the endotracheal tube, which are going to test about the conduction around the larynx. If you are wondering how is this thing working, the basic logic is that this is the larynx and this is the trachea, and majority of these nerve conducting devices, what they do is that they depend upon the vagus nerve as their baseline. So what they do is that they will take their monitors and they will apply some electrode on the vagus nerve, and the vagus nerve gives a particular pattern. Okay. And remember that all these branches that come from these ones, the external laryngeal, the recurrent laryngeal, or are technically the branches of the vagus. And so what they do is that if one is a fixed electrode like this one, they go on with the probe, and this probe in relation with this may show an impulse. So this is how the basis of a nerve monitoring is done in thyroid. But again, this is a very new concept. It is worth knowing the picture, and hence I give you this picture to know about. You'll be very rarely getting to see this at all in your practice. But this is something I think your department or your anesthesiologist will be using this very frequently. Can you tell me what is this technical thing used for?
For tracheomalacia.
Very good. This is used for intubation in a case of a multinodular goiter with a tracheomalacia, or tracheomalacia is the perfect word that I was looking for. What is so special about this tube, particularly in the intraoperative and the postoperative period? Can you tell that to me? What is so special with this tube in the intraoperative period? Number one, it is a stiff tube. In contrast with, as you have said very rightly, if the thyroid is this huge and the thyroid is compressing the trachea, this tube is going to go and it is going to maintain that pressure in the trachea so that the trachea is maintained. So it makes an easier intubation for the anesthesiologist. What is the special thing in post-operative? This is the most important, as you have said. A tracheomalacia will make the trachea very floppy because the cartilages are eroded. So you need a support in the trachea to prevent the tracheal collapse. And usually patients who have a tracheomalacia, anesthesiologists are going to keep this tube for 48 hours to 72 hours so that there is a local fibrosis. And during the operation, what you can also do is that if this is the trachea, you can take a few stitches with the strap muscles in place to secure the trachea. In the rarest of scenarios, always remember, we used to counsel the patient to have a tracheostomy done as a temporary maneuver, and the dictum is still okay. However, with the use of good ventilation, we go for an elective ventilation with these big, horrendous, say, these thyroids. But you are always required to tell your patient you may require a tracheostomy in the postoperative period. So this is the rationale about doing this. Number one. Number two, in the last question, all of you have said a CT chest, and this is something that was very happy. What is the other most important investigation that you must do before you plan the operation after a CT chest?
Indirect laryngeal.
No, not happy with laryngoscopy. But laryngoscopy is done in every case of thyroid. What is so special in this patient? Retrosternal goiter, bad goiters, tracheomalacia. What is so special? Bailey Love said, Bailey Love even gives you a picture of that. This is something called as a flow volume curve in a spirometry. This is something that is mandatory before you take the patient for an anesthesia. This is going to tell you how much amount of compression is on the airway. For both you, me, and the anesthesiologist, this is something of a very important thing along with a CT that tells you about the flow volume curve on a spirometry. Or a lung function test will be a simple word to use. Okay, yeah, someone was asking a query, please.
Sir, when we will extubate in tracheomalacia patients? Sir?
It's difficult to comment, sir. It all depends upon, you can give a trial of extubation. Usually, if you talk to anesthesiologists and ENT guys, they will advocate a 72-hour window. and they will not take out the patient from the ITU after an extubation. They keep the patient admitted for next 7 to 10 days until and unless the patient has a good voice. Some people perform a flexible laryngoscopy in the post-op day 5th to 7th to see up to the bronchus and particularly to see the recurrent laryngeal nerve. Okay.
Thank
So
you.
what is the post-operative use of normal tubes?
The post-operative use, sir, I've told you, is to maintain the contour of the trachea for maintaining a ventilation. That is the important point about an normal tube. It maintains a fixed stature of the trachea. Remember that the trachea Malaysia, the trachea will collapse. If you use a plain tube, the trachea is on the verge of getting collapsed. So this tube maintains that state.
Thank you, sir.
Let us go to this one. This is a simple one. What is this?